إنزين. So okay, so okay, so we're good to start, right? Okay, so this, yani we had done a couple of previous EP conferences in the past. We did a couple of themes in the past. Please, guys, mute yourself, please.
ثروة قيمتها الثقافية والفنية مش قيمتها المادية وبس. أكيد مشاهدتها متعة ما تتقدرش. لو قبلتي دعوتي وجيتي زرتيني في بيتي هتبقى تحت أمرك.
Okay. إنزين. So we did a couple of things before, yani. So this is a new theme, which is more case presentation. It was an interesting case that I encountered recently, and I thought it's good to share. Okay. Okay. So a couple of slides from this presentation was taken from Professor Priori lecture that was given back in 2017. She at a seminar or webinar through SADS, which is Sudden Arrhythmia Death Syndrome Foundation or organization website. Okay, so she is a very well-known electrophysiologist plus genetic arrhythmia expert. Okay, okay. So before I start, I know I have a couple of visitors today. So this is our YouTube channel. There are already 5 previously recorded seminars or presentations that are uploaded. We did more, but I did not upload all of them for a couple of reasons. But these are the 5 presentations that are already uploaded. So please feel free to subscribe and view them, okay? Okay, and most of them are pediatric / junior cardiology level, okay? So it should be relevant for most people, okay? Okay, so let's start. So this was a patient who I recently encountered again. This patient had history back in year 2000. He was 14 years of age at the time. He had, let me do this. Okay, he had cardiac arrest around 9 minutes in duration while having an argument with a friend. And he subsequently has suffered from neurological insult after this cardiac arrest. However, now he's fully recovered, okay? He, at the time, after his resuscitation, his ECG was noted to have prolonged QT interval. However, this was an ECG post-arrest. We did not have an ECG pre-arrest to confirm the QT interval duration. Just FYI for your information, oftentimes post-arrest, the QT interval is often prolonged secondary to the arrest, not because of congenital through long QT syndrome, okay? So guys, if you have any questions, please interrupt me at any time, okay? I muted everyone, but I think you can unmute yourself and speak up, okay? And let me know if you cannot, okay? So I don't have that ECG available because it was done many, many years ago. But per records, it was normal except for some prolongation of the QT interval. He had severe asthma at the time in general, I mean, until now. So beta blockers were not started back then because of his severe asthma and frequent asthma exacerbations and admissions, okay? So he was not treated, eventually discharged. Diagnosis was uncertain, like idiopathic. However, he kept having repeated episodes of syncope for the next 2 years. And the patient, for that reason, the patient underwent transvenous ICD. Okay, any questions so far?
لا يا دكتور
clear.
محمد.
Okay, good. Is there? I
Dr.
just want to make sure
Muhammad, one
people.
question, please.
Sorry?
About one question, please, Dr.
Yeah.
Muhammad, about beta
Yeah.
blocker and
Yeah.
the contraindication in severe asthma.
Yeah.
We cannot use selective beta blocker like beta 1 blocker or something for this arrhythmia or not?
Yeah, I mean, of course, we can, but yeah, it's probably, you know, if you use selective beta blockers, that would affect asthma less. However, the selective beta blockers are usually less potent for arrhythmia compared to the non-selective ones. And I will talk about this in a minute. But yes, they can. They did not do back then. I mean, I wasn't around back then. So I don't know what were the, you know, circumstances, but they elected not to start any medications, specifically beta blockers. Of course, I mean, I don't think it was a rational decision, but this is what was done. So the patient kept having repeated symptoms of, I mean, he did not have cardiac arrest, but he had frequent syncopal episodes. So he underwent transvenous ICD at the age of 16 years, which this was in 2002, okay? And again, the diagnosis remained unknown, idiopathic. So they eventually labeled him as idiopathic ventricular fibrillation, okay? Okay, so this is from Kuwait, huh? So this is our patient, okay? So since after the transvenous ICD implant, he had multiple episodes of VF, VT, recordings from his device. And as such, he had appropriate shocks to terminate the VT VFib. Some of them were successful, some of them were not successful, but nevertheless, he had many arrhythmic events. He was an avid swimmer, and most events were during activity, especially swimming, okay? And however, sometimes his symptoms were related to emotional stress, okay? So because of his frequent symptomatic arrhythmias, people started him on flecainide, okay? Again, because given the asthma, his asthma is very bad, apparently. I mean, I just met him the other day, and it's not a mild, he gets admitted to the ICU with steroids and nebs and so forth. So it's apparently very bad asthma, okay? So flecainide was started with apparent decreased arrhythmia burden, okay? So there was definitely improvement in terms of VT and VFib with flecainide. However, he was not compliant. I mean, back then he was like a teenager, young adult. And for some reason, he said there was no specific side effect. He just did not want to continue using flecainide, okay? There's no specific reason. He denied any specific reason, okay? So, but definitely flecainide helped, okay? Okay, so of course, eventually people had advised him to stop being active because again, when he's active, he has symptoms. So eventually he quit swimming and his arrhythmias, you know, went down, okay? So he stopped flecainide, but he's also stopped swimming. And then he since 2010 and onwards, he did not have any shock, okay? He does have some palpitations, but no shocks, okay? Again, since he stopped being active, okay? Okay, so in terms of family history, it's very interesting, very, you know, unfortunate, bad family history. So his sister died when he was 17 years of age. She was dancing in a wedding, okay? And this sister, she died like before his presentation, and this was the first family member that died suddenly, okay? This was many years ago, before year 2000, okay? And then he also had 3 nieces died, one of them while dancing in another wedding. She was 16 years at the time. Another one after being yelled at in school. So if you remember, for those who were in Kuwait like 6-7 years ago, there was an incident in one school that a teacher was upset with a student. She yelled at her / maybe just, you know, I don't remember the details, but there was some yelling to the student, and that student suddenly died in the school. And this grabbed media attention. Do you guys remember that event? I don't know whether you guys remember, but this was his niece, okay? She was 11 years at the time. and the teacher was in trouble because she was the reason why this child died, right? So and this was very talked about back then. Anyways, and another niece died after thunderstorm and thunder sound, and she got scared and she suddenly died at 10 years of age. Okay, and then he had two nephews that also died, one while playing soccer at 22 years of age, and one following a physical fight at 19 years of age. Okay, I mean physical fight meaning they did not punch him to death. While he was fighting, he suddenly collapsed. Okay, not because of traumatic death. Okay, so that's very impressive family history, right? Okay, it's a big family. He has 9 brothers and sisters. So but of course 6 people died from this family. Okay, like suddenly, young people. He had another niece who arrested also after dancing. However, she survived, so she's now on. I don't know the details of that niece, but she is on beta blocker, we believe, and she has an ICD implanted already. Okay, and he has another niece and nephew who are who received ICDs, and but we don't know the details. I don't know them, and he doesn't know the details. Okay, so there's definitely many family members who died, and some family members who had symptoms, however are now being treated with ICDs plus minus beta blockers. Okay, and so far the diagnosis is unknown. The family is labeled as idiopathic VFib. Okay. So, and FYI, his mom and dad are non-consanguineous. Okay. So this is his ECG. I mean, there are many ECGs in his file, but this is one of the cleanest ECGs. Okay. Any comments? Now, I guess you guys need to help me here a little bit. So anyone want to volunteer and just look at this ECG and let me know if he or she is worried about something. This is off flecainide, off beta blocker, no meds, just an ECG. While he was, stable, not post-arrest or anything.
برقادة looks برقادة.
Okay, منو هذا علي? Yeah, Ali.
برقادة.
Okay. So why do you say it's Brugada?
V1
Yeah. So V1 ايش فيها؟ علي ايش فيها V1؟ انا قاعد اسمع سمعت ابسلون ويف، صح؟ في احد قال ابسلون ويف؟
ابسلون؟
ما ادري. I thought someone said epsilon wave. Anyways, علي انت you say Brugada. Why do you say Brugada?
بيبقى
ST segment elevation.
elevation.
دكتور متولي شلونك؟ Okay, I don't know, Mitwali, you were here from the beginning, or you just you heard the story, right? Okay.
I heard the story, yes.
Okay, good. Okay, so people are worried about Brugada, right?
Yes.
Anything else people are worried about? Well, that's it. Okay. So, yes, Brugada, this ECG might make you think of Brugada. Okay. However, Brugada does not look like that. Okay. I mean, Brugada is similar to this, but not exactly this. Okay. And I can show there is a definition of Brugada. I mean, first of all, you need at least two small squares of ST segment elevation in two consecutive leads. Okay. Here, there's no two small squares elevation. And usually the type 1 is more it is here, if you see my mouse, in type 1 usually it goes up and then the angle, and then it goes to baseline with a less steep angulation. Okay, so it goes up and then slowly comes down. Here it comes down rapidly, and then T wave is, there's T wave. So this is more RSR prime or incomplete right bundle looking rather than Brugada looking, okay? And I can show you Brugada ECG now while, let me just, and I thought someone would say Brugada and I here. No, not this. And I thought I had Brugada. You can see my screen now, right?
Yes.
Okay. I thought someone would worry about Brugada, but this is more typical of Brugada. You see, where is it? Oh, okay, you see more. First of all, there is at least 2 small squares of elevation. Okay, and then it's more, straight line coming down rather than an RSR prime pattern. Okay, this is from Wikipedia. We need a better source. There is okay, so this is more a nicer ECG of Brugada. Yeah, this is a nice website, by the way. Here you see, so there's definitely at least more than 2 small squares elevation, and plus there is there's not an acute slope of returning to baseline. Okay, it's just there is less steep of slope returning baseline. Okay, versus in our case, sorry, here there's definitely acute or sharp or steep return to baseline. Okay, before the true S segment. So there's less S segment elevation, less than 2 small squares, and there's quick return to almost baseline. Okay, so yes, you should think of Brugada, but this is not very typical of Brugada at all. Okay, so if I see this and you don't tell me any history, I would call this incomplete right bundle, RSR prime, right ventricular delay, and I would not call this Brugada. Okay, but it's a good thought. Okay, we can talk about Brugada in another presentation one day. But yes, Brugada is similar to this, but not exactly. Definitely T waves are inverted in lead 1, lead 2, lead 3. This is abnormal for an adult. So that's definitely abnormal. However, remember V1, V2, and V3 location is often inaccurate. بمعنى, ideally, V1 and V2 should be placed in which intercostal space? Do you guys know? Normally, where do you place the V1, V2 leads?
Second intercostal space.
No, fourth intercostal space. Normally.
4.
Okay, fourth. So, but how often do you see the nurses counting intercostal space and throwing the leads? Never, right? They just guess and they just throw the lead, right? So it's often not in the 4th intercostal space, it's often above the 4th intercostal space, okay? So when you go higher, you would get RSR looking or incomplete right bundle looking finding, okay? Which is normal, okay? So if you go above the 4th intercostal space, you often see such an ECG, okay? So, and with T-wave inversion. So this is probably for this patient, just misplaced leads rather than true incomplete right bundle branch morphology, okay? However, I cannot confirm that because I wasn't there, but this would be my suspicion, okay? So again, one day when you're placing ECG leads, just take V1, V2 from 4th intercostal space and just throw them into 2nd and 3rd, and you will see SC segment elevation a little bit, T-wave inversion, and RSR prime change into the QRS in lead V1, V2 mainly, okay? And then again, the nurses are not very accurate in where are they positioning the V1, V2. So often you see this and we overread the ECG and we call it RSR prime and, incomplete right bundle, and we worry about ASD and we order an unnecessarily echo, okay? So, so good thinking, but it's not Brugada, okay? Okay, so this ECG actually otherwise is relatively normal, okay? There's nothing much impressive about this ECG except like we said, T-wave inversion and RSR prime pattern in V1 and V2, which I think it's lead positioning issue. It's not a true abnormal finding. Okay, makes sense, guys? Okay.
Okay.
Okay, definitely the QT interval is not long or not very short. I mean, there's something called short QT syndrome as well. So it's not very long, it's not very short. I mean, here there are prominent U waves, but I don't know what to make of it as so much. I mean, that specific disease, by the way, that I would eventually, we would eventually diagnose him with, has some usual prominence of the U waves, but it's not part of the diagnostic criteria, okay? But just keep that in mind, okay? There are definitely U waves that are, you know, a little bit prominent, more than what you usually see, right? Right, guys? You see them? So T, U, T, U, you know, there's a U wave here, U wave here. Often you see U waves in V2, V3, but because of high positioning of the leads, you don't see them here. Anyways, okay? But otherwise, normal ECG, okay? Okay. So now he is being stressed, or you know, he's undergoing exercise stress test. Okay. Okay. So now his heart rate is 97, and what do you see in this stress test?
BVC when
Okay.
He extra systole.
Yeah. So I heard PVCs. Okay. So there is definitely PVC. This guy. I mean, if you look at the rhythm strip, there is a one PVC here, right? And another PVC here, right? Sorry. And another PVC here, right? There's at least 3 PVCs, 1, 2, and 3, right? Agree? Okay. I know they look funny, but these are PVCs, okay? There are T waves subsequent to them. They're not artifact, and there's a gap in heart rate, you know, so there's definitely PVC with reset of the sinus rate, okay? So those PVC, so whenever you see PVC, you wanna try to you know, to see the morphology of the PVC in order to try to locate where is it coming from, which is a little bit advanced. I wouldn't worry about it right now here, but you want to make sure the PVCs are either monomorphic or polymorphic. So in this case, are they monomorphic or polymorphic?
Polymorphic.
Poly, right? This is definitely different than this, right? I don't know what,
Yes.
yeah, you said polymorphic, صح? So this is positive, this is negative in this lead. This looks funny. I don't know what this is similar to this. So at least there are 2 morphologies, if not all of them are different. Each and every one is different, right? Agree? Okay. So another thing to note, if you see a PVC, how close it is to the T wave, the previous T wave. Because if it's on top of the previous T wave, which we call short coupling interval, this is dangerous because the PVC that is on a T wave might induce VF, okay? So whenever you see PVCs, besides trying to figure out where is it coming from, make note of whether it's polymorphic or monomorphic, and how close are they to the previous T wave or the previous QRS. The closer they are, the bad, you know, it's a bad sign. The further away they are, it's a better sign, okay? Okay, so now his heart is 97, and he had 2 or 3 different PVCs. Okay, so now heart rate around the same, still he's running. So you see, what do you see here again? So
PVCs again.
hello, PVCs. So there's one here, one here, and one here, right? These 3 are very similar to each other, so maybe monomorphic, but definitely comparing to the previous ECG, there are definitely at least 2 different morphologies, okay? So now he's still exercising. Now his heart is 150, okay? So what do you see here? Oh, guys, what do you see here? I know it looks messy. It was messy.
Couplets and
Yeah. So
and trigymny.
okay, so you see, I mean, this is probably a sinus beat, probably. I don't know whether it's a PAC or a sinus beat, difficult to tell. but there's definitely a PVC here, right? Which looks different than the previous ones that we just saw, right? And there is a sinus node reset here. There's a sinus beat here, another PVC that looks the same as this one. Sinus, and then 2 couplets, right? And then sinus QRSs, and then another PVC here, okay? This is probably a fusion, meaning it's a PVC with a sinus beat that are fusing together. So it's a narrowish looking PVC. Makes sense, guys? And then there is definitely PVC here, PVC here, PVC here. There's some artifact here. So PVC, 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 and another PVC. So many PVCs, right? And there's couplets here, there's maybe triplets here, right? So definitely increasing in PVC appearance when his heart rate is at least at 150, plus very different morphologies, right? So we know at least there are 3 or 4 different morphologies to in this patient, right? If you remember the previous morphologies, plus there's one here that's upright and wide, and there's one here that's negative, right? Make sense, guys? And there's another way here that looks negative but also wide. This is negative but narrow, okay? So there's 4, 5, 6, 7 different PVC morphologies for that patient, okay? So that's very unusual, very strange, very abnormal, okay? And I wasn't there at the time of the exercise stress test that was done for this patient. He was off flecainide and off any drugs, but he then stopped exercising because he did not feel right. And then now his heart rate is coming down, and then ectopy here, the PVCs are coming down as the heart rate is coming down, okay? So there's only one PVC here, and the heart rate now is 120, no more PVCs, and so forth, okay? So what did we learn from this exercise stress test is that the patient had normal ECG, or relatively normal ECG, or unimpressive ECG. However, he developed polymorphic PVCs, couplets, triplets, especially at peak exercise, right? And then his ectopy decreased and normalized when he's resting, right? You agree, guys?
Yes.
Yes.
Okay. So knowing this and knowing the history, what comes in mind in terms of differential diagnosis? What do you think now? I mean, are you still going to call them idiopathic VT/VFib, or you would think of something, not idiopathic? We thought, we said that Brugada, we can keep Brugada in the back of our mind, but how do Brugada patients present? Meaning, what triggers Brugada arrhythmias? Do you guys know?
I think VTAC and
No, but
VFib.
what triggers VFib in Brugada? Yani what usually makes patients who are with Brugada makes them sick?
Sleeping.
Sleep is yes, usually. More usually, but it often happens when they are asleep or when they are febrile. If they are sick with fever, this is a trigger, and alcohol intake is another trigger. Okay. In our family history, did I say fever? No, right? Did I say while asleep? No, right? Did I say there is a history of alcohol ingestion or intoxication? No, right? So nothing in this family sounds like Brugada. And also Brugada usually doesn't present at this age, 10, 11, 16 years old, 14 years old. Brugada is more, 30, 40 years old of age and onwards, okay? In pediatric, we don't see many Brugada patients. This is more adult disease, okay? Makes sense, guys? So yes, Brugada, you can keep it in the back of your mind, but I'm not, I don't think it's Brugada for sure. So what else that you might think of?
Sorry, Mohammed, about the echo. Echo was done normal?
Yes, sorry, echo normal. Yes.
Okay.
Good question. Sorry.
Echo normal. Yes.
Echo normal, and by the way, CT coronary angiograms was normal. So they ruled out ischemic insult or ischemia causing VTVF, and echo was normal. Yeah, sorry, Nabil,
Yes.
شنو قلت؟
Electrolytes are normal for this
Electrolytes
patient.
normal. Yes, electrolytes normal.
We can think of arrhythmogenic right ventricular dysplasia.
ARVC. Yes, you can think of ARVC, but like especially when you have T-wave inversions in the right-sided leads. But echo was normal. We didn't do cardiac MRI, but echo was normal. MRI wasn't done, but cardiac echo was normal. You can, there is a criteria to diagnose ARVC, including Holter, ECG, MRI, and echo and pathology and so forth. But ARVC could be in your differential, sure. But what else? Okay, so are you aware of any arrhythmia that happens with exercise? Like what syndrome?
Oh, yeah. Catecholamine induced.
Yes. So there's something called catecholaminergic polymorphic ventricular tachycardia, CPVT.
Yes.
And long QT syndrome. I mean, long QT syndrome type 1 is exercise induced, and it's very well known for swimming in particular to induce, cardiac arrest in long QT type 1 especially. Okay. صح?
Yes.
So for those who didn't know, swimming is a well-known trigger for long QT type 1. Okay. And of course, CPVT, catecholaminergic polymorphic ventricular tachycardia. That's a disease, min isme, catecholaminergic, meaning when there's increased adrenaline, you get polymorphic ventricular tachycardia. So when do you have increased adrenaline? When you're exercising, right? Or when you are upset, right? Okay, so your differential definitely should include CPVT and long QT syndrome. His ECG is very unsuggestive or not suggestive of long QT syndrome. So CPVT should be in your main differential. ARVC is a differential, of course, but if the MRI was normal, then you probably would not, this patient would not fit the criteria for ARVC. You need, as I said, there are major and minor criteria for your ARVC, which we can review whether today or next time. But this patient has nothing to suggest ARVC except T-wave inversion in V1, V2, V3. This is the only minor criteria that this patient has, okay? His Holter did not show frequent PVCs at rest, and ARVC usually they have PVCs at rest. Okay. So CPVT or long QT syndrome is definitely should be included in your differential. And given the ECG and exercise stress test, so with long QT syndrome, the exercise stress test would show QT prolongation usually during exercise and during recovery. So there will be maladaptation of QT. So usually when normal people, the QT shortens during exercise, and but in long QT syndrome patient, the QT doesn't shorten during exercise, and when they are resting just immediately after exercise, it actually artificially prolongs. Okay, so that's why for our long QT patients, we often do exercise stress test and we wait for 7 to 10 minutes after exercise and do repeated QT measurements, okay? Because they might have abnormal QT prolongation, not only during exercise, but also during recovery, okay? But this patient had a short QT interval throughout, okay? Okay, so CPVT is definitely is high in your differential. Remember, all his symptoms were during swimming or during being upset. And when he stopped swimming, he never had a shock, okay? His history, his family history, all the deaths were when people were active, for example, dancing, or when they are scared or there is some stress. For example, the thunderstorm sound or the yelling in school. Okay, so CPVT really is, this family is very typical for CPVT. And this is an interesting case because I know you guys are not seeing CPVT patients. It's very rare. This is my first family in Kuwait with CPVT. I had seen a couple of families when I was abroad, but in Kuwait, this is my first CPVT suspicious family. So how did I encounter this family? The adult electrophysiologist who is seeing dad, he referred his kids to me to evaluate the risk of ventricular fibrillation, because again, their dad and their aunties and nephews and nieces, a couple of them, died, like, So he referred the kids to me. And then when I took history, I was suspicious of CPVT. So what did I do? I ordered genetics. Okay. So this is genetics. So dad came back positive for pathogenic mutation in RYR2 gene, which is called ryanodine receptor 2 gene, which is which causes CPVT. Okay, and I'll explain what is this gene in a minute. So his son and daughter that they were referred to me, they both have the gene as well. However, I did Holter on them. I did exercise stress tests on this 5 years old, and they did not have any PVCs or ectopy, but they are genotype positive. So I started them on Nadolol, and I'll explain why later. Despite having negative phenotype, we still started beta blocker therapy because of their positive genotype, and I'll explain this later. Okay, so this is the so the GeneDx and InVT. These are major genetic companies or lab companies, and both these companies labeled that mutation as pathogenic or likely pathogenic. So this patient had, this is the exact detail of the mutation. He had he had glutamic acid, So he had glutamic acid being substituted with lysine, okay? So these are both amino acids. Glutamic acid is usually negative charged amino acid. Lysine is positively charged amino acid. So when the protein should have glutamic acid at this location. However, the new protein of this patient had lysine instead of glutamic acid. And lysine and glutamic acid are different. So the function of the protein gets affected. And if you do mass screening, so for example, they're in Northern Europe, they had 400 normal people, and they did not identify any normal individual with that glutamic acid lysine replacement. So that tells you that normal people does not have that mutation. So that mutation is more likely to cause disease. Okay, and this has been repeated in a couple of other registries or ancestry in other continents. Okay, so in addition, the geneticists are now more advanced, and they can study, they can reproduce that diseased protein and analyze whether it will function as normal or not. And the algorithms that do that suggested a very disruptive protein or receptor when you do that change, when you substitute glutamic acid with lysine. Okay, so not only that, there are a couple of publications, for example, in this one, with patients with phenotype typical of CPVT with that finding. Okay, so in other words, there's strong evidence that mutation actually causes CPVT. Okay, so that's why it's labeled as pathogenic or likely pathogenic in these two different companies. Okay, so and our patient is typical CPVT. So honestly, I don't care what the genotype would show. This is CPVT until proven otherwise. Okay. Okay. So, I mean, when you order genetic testings, of course, you have to know how to interpret them. Okay. And this is, you know, a specialty by itself. So, so you have to understand, you know, how to interpret the gene result, because oftentimes you get results that are variant of unknown significance, meaning there is variant that is diagnosed, but it's not labeled as pathogenic, meaning there's no evidence that this variant would cause disease. So you don't order genetic testing left or right. You only order genetic testing if you have a strong phenotype, so that the genetic testing would be supportive. If you have a weak phenotype, meaning a patient who there's nothing clear, you don't order gene testing for no good reason, and then you'll get something that is abnormal, but you're not sure whether it causes disease or not. Does that make sense, guys?
Yes.
So you only
Totally agree. Yes.
Yeah. Okay. So you only order gene panels when you have a very strong suspicion of a specific disease. You have to have high positive, high pre-test probability of positive result. Okay. 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 Otherwise, you don't order gene test. But this patient, of course, we really are suspicious of something bad, such as CPVT, and thankfully, well, not thankfully, but but the gene result came back supporting our suspicion. Okay. Okay. So that is the exact. So this is the cartoon of the receptor, the ryanodine receptor, which is this. You know, this is the receptor, and it extends. Although it extends. This is the cell membrane of the sarcoplasmic reticulum, by the way. So we're going into basic science here. Sorry about that, but in order to understand genes, the arrhythmias that are from gene diseases or gene mutations, you have to go to basic science a little bit. So that's the ryanodine receptor in the sarcoplasmic reticulum, and then these are the purple bars are where the disease, where the mutations are often. Most mutations are happening, in these hotspots: number 1, number 2, number 3, and number 4. And then these red dots are confirmed CPVT patients with mutations in these locations, but less common. Okay, so in our patient, our mutation was previously reported, and exactly it's in here. Okay, so definitely previously reported, and it's close to a number 2 hot spot. Okay, so what is CPVT again? So it's an important cause of juvenile sudden death. Okay, young patients who have with cardiac arrest, and hopefully, of course, when you see them, they usually survive their cardiac arrest, like in our patient. So CPVT is a suspect almost always. So it's catecholamine induced arrhythmia or adrenaline induced arrhythmias, and the arrhythmias are usually either the classical arrhythmia is bidirectional ventricular tachycardia. This is the classical arrhythmia. When you see bidirectional VT, meaning 1 positive, 1 negative, 1 positive, 1 negative, 1 positive, 1 negative QRS, this is diagnostic of CPVT. However, you don't see that each and every time. You might see polymorphic VT, or sometimes even atrial arrhythmias as well. Okay, so they have normal baseline ECG because they don't have any cardiomyopathy. Their AV node is normal. Their QT interval is normal, so they will have normal sinus activity, normal PR interval, no cardiomyopathy, so the QRS is nice and narrow, and QT interval is normal. So they have normal ECG. However, an echo is normal because, again, there's no structural, disease like the IARVC. However, when you stress them, the ECG goes abnormal. Okay, and that's why we stress patients who presents with funny syncope or history of cardiac arrest. If the diagnosis is not clear, we almost always do stress ECG. Okay. Okay. So the arrhythmias of CPVT are usually reproducible, meaning the patient. So index patient here, he started having PVCs at around the heart rate of 93, 95 beats per minute. And each and every time, if you repeat stress ECG for him, when his heart rate is below 90, he'll be fine. Whenever he reaches his threshold of 95 beats per minute, his arrhythmia would start happening. Okay, so there is usually a threshold for arrhythmia to happen in each and every CPVT patient, usually around between 90 to 110 beats per minute. Okay. So, and like we said, the patient might have atrial arrhythmias, not just ventricular arrhythmia, but the VT, it's classically it's bidirectional, which is here. So you have one positive, one negative deflection, positive, negative deflection, positive, negative deflection. This is classical VT for CPVT. So if you see this ECG in someone, this is CPVT. There's nothing that causes the exact same arrhythmia except CPVT. Okay, this is very classical. However, you might see polymorphic tachycardia, polymorphic VT. Okay, like our patient and these examples. Or of course, when they die, it's because of ventricular fibrillation. So they are, in this case, for example, this patient was having bidirectional VT and suddenly goes to VF. Okay. And then of course he arrests. Okay. Okay. When people have VT or PVCs, they are often asymptomatic because they are again young, teens and healthy with no cardiomyopathy, strong, hearts. So they often are very asymptomatic, except unfortunately when they have, significant arrhythmia such as VF, of course, then they will, they will manifest. Okay. So unfortunately, many of them are silent until they die. Okay. So this patient was very lucky. He had cardiac arrest for 9 minutes, if you remember, but he was revived. Okay. So, and now his kids, he's diagnosed and his kids are diagnosed before anything bad happened to them. So that's, hopefully his kids are now safe. Okay. Okay. So back to genetics. I know you guys are not very, you guys are not into genetics, but we have to mention genetics when we talk about arrhythmia, inherited arrhythmias. Okay. So it's a highly penetrant disease, meaning in the disease, once you inherit the gene, you're usually you will be symptomatic sooner or later. Okay, not like lung QT syndrome. Lung QT syndrome, very often they are asymptomatic, but when you have CPVT, sooner or later you will develop symptoms. Okay, it's very rare that you will have no symptoms, and that's why his kids are already on drugs. Okay, because they will have symptoms for sure. Of course, maybe not now, but in five years from today, they probably have symptoms. And the first symptom might be VF. So we might lose that patient. So that's why we immediately, once we diagnose a CPVT patient, he has to be on drugs. Okay. And I'll talk about the treatment in details later. Okay. So that is the sarcoplasmic reticulum. If you remember from med school, sarcoplasmic reticulum is where calcium is stored. Okay. And ryanodine receptor is a receptor on the cell membrane of the sarcoplasmic reticulum that controls the release of calcium into the cell. Okay, so if that receptor is malformed, calcium would leak into the cell. Okay, and that calcium leak into the cell would causes abnormal depolarization of the cell and hence arrhythmia. Okay. So when you have CPVT, around 60% of patients with CPVT has a pathogenic mutation in RYR2 gene. Okay, and this is also called CPVT type 1, which is the commonest type. Okay, like in lung QT we have type 1, type 2, type 3, type 16. In CPVT we have now 4 types. Okay, so type 1, the commonest. It's an abnormal mutation in the ryanodine receptor, which again controls calcium release into the cell from the sarcoplasmic reticulum. It's an autosomal dominant disease, meaning you only need one mutation in one gene to manifest the disease. Okay, so type 2 or 3 and 4 are are very rare, less common, and involve mutations in calciquetrin gene, triadine gene, and calmodulin gene, okay? And all these genes are within the sarcoplasmic reticulum. They function, they function within the sarcoplasmic, their protein products function within the sarcoplasmic reticulum, and they somehow control the release of calcium into the cell, okay? So, and of note, the type 2 and type 3 are recessive, meaning you need 2 mutations to manifest the disease, okay? So that's why they are less common as well, okay? So let's focus on ryanodine receptor because that's the most common CPVT type, okay? So questions so far? I know it's a little bit complex here, but it's, yes, I'm simplifying it. Abnormal calcium release into cell causes abnormal depolarization and arrhythmias, okay? Makes sense? Questions, guys? No? Okay. So, okay, so again, so sarcoplasmic reticulum, when you have, pathogenic mutation in one of these genes, the sarcoplasmic reticulum is less able to contain the calcium inside of it. So calcium, you can see my mouse, right? Calcium leaks outside the sarcoplasmic reticulum, okay? And then when calcium is released outside, it is exchanged with the sodium using the sodium calcium exchanger. So then calcium goes out and three sodium elements go into the cell. And we all know what sodium causes when it enters the cell. It increases the voltage of the cell so that it initiates depolarization. If you remember again from your med school, action potential is, there are phases in action potential. Phase 0 is depolarization, and this is mediated by rapid sodium influx into the cell. So the cell potential is -90, is negative side, and then when sodium goes inside the cell, of course it turns into positive, okay? And then this causes the depolarization or action potential or contraction of the cell, okay? So in this case, you have extra depolarization from that mutation, and this is called delayed after depolarization, meaning you already depolarized, but there's another depolarization after you depolarized, okay? So that's why you get the ectopy and sometimes the runs and VF. Make sense, guys, so far?
Okay.
Yes? Questions? No
يعني
question.
هو definite diagnosis only genetic. يعني there is no.
Well, there is, if you see bidirectional VT, that's pathognomonic of CPVT, the bidirectional VT, because you will not see it anywhere else. But this is not all, we're not always lucky enough to get the bidirectional VT. But again, if you have someone who has VT when exercising, you have to be very suspicious of CPVT, and genotyping often would confirm the diagnosis. 80% of patients with CPVT would have positive gene result, okay? So it's not 100%, 80%, okay? There is a diagnostic criteria for CPVT that I will show you. I'll tell you exactly how to diagnose CPVT, okay? Okay, but I meant the pathophysiology makes sense? Because
yes,
we're basic science and genes and receptors, so it's a little bit confusing. But this is as simple as I can make it, okay? Okay, so natural history of CPVT is as such. So when people are born with CPVT, okay, by the age of around 10 years, okay, almost 30% of them would have symptoms, okay? This is based on a registry of 300 CPVT patients, in Italy, okay? So I believe in Italy. So, and then when the patients are around 40 years of age, almost 79% of those patients would have symptoms, okay? So again, it's highly penetrant. Again, it's highly symptomatic. So by 40 years of age, 80% of people would have symptoms, and these symptoms are not a joke. The symptoms could be arrest, and whether aborted cardiac arrest or patient dying from it. Okay, so 80% of patients at age 40 would have symptoms. Okay, significant symptoms, of course, if they are not treated. So that disease should be. That's why you should, whenever you diagnose someone with CPVT, you should start therapy. Okay, because natural history is not good. Okay. Okay. Makes sense. So that graph makes sense, right? Okay. So this is how you diagnose CPVT, Dr. Mitwalli. So you have the North American guidelines and you have the European guidelines. Okay, they are a little bit different, but they are very similar. So CPVT is diagnosed if you have normal heart, normal ECG, however, unexplained exercise or bidirectional exercise or bidirectional VT or pulmonary VT. So you have exercise bidirectional or pulmonary VT, or exercise-induced VT in an individual less than 40. Okay, so that's how you diagnose CPVT. As simple as this. Okay, so you don't need genetics to diagnose CPVT if you have exercise-induced bidirectional VT or exercise-induced polymorphic VT. Okay, or any VT. Okay, in someone who's less than 40 years of age. Also, CPVT is also diagnosed in patients who have a pathogenic gene mutation, like our patient. Okay. Also, CPVT is diagnosed in family members of a CPVT index case, meaning definite CPVT case, again, who manifest exercise-induced PVCs or bidirectional polymorphic VT. Okay, so if this patient, any family member of this patient with exercise-induced ectopy is CPVT until proven otherwise. Okay, and CPVT can be diagnosed in the absence of any structural heart disease, normal ECG, unexplained exercise, or bidirectional VT or pulmonary VT in individuals above 40. Okay, so that 40 could be, it could be below 40 or above 40. Okay, so that's the, Mohammed, did I answer your question here? Just how you diagnose CPVT. Okay, so if you use the European one, which is more simple, so CPVT is diagnosed in the presence of normal heart, normal ECG, and exercise-induced VT or emotion-induced VT. Okay, or CPVT is diagnosed in pathogenic mutations. Okay. Okay.
Okay.
Okay. Okay. So therapy. I should have showed this next slide. But for therapy, so now the question is, what do we now? We have CPVT patient. Of course, we have to treat that patient. So what do? Your drug of choice is beta blockers. I mean, it's simple. It's adrenaline-induced arrhythmia. You give beta blockers, which are adrenaline blockers, right? Makes sense, right? So the beta blockers, of course, reduce threshold for developing VT, ectopy, and you remember the threshold that I told you. Each patient has a specific threshold. Then only then the VT starts to happen. So this patient who is off drugs would have, let's say, in our patient, his off-drug threshold was around 95 beats per minute. When he takes beta blockers, it will probably be more than 95 beats per minute. Okay, which is good because it's more difficult to increase your heart rate. Of course, it's more difficult to increase your heart rate. The higher that threshold, the higher the heart rate is. Okay, so it's easy to go to 95 beats per minute if you're just walking around at home. But if it's 120, of course, you need to run to get to 120, right? So the higher the threshold, the better it is for the patient, right? So the beta blocker help in that way. Plus, of course, it decreases the ectopy by way of blocking the adrenaline receptors. Okay, guys? Okay. So which beta blocker of choice? Of course, there are many beta blockers. We don't do bisoprolol. We don't do atenolol. Instead, we do non-selective beta blockers that are like nadolol or propranolol. Okay, so of course nadolol is once a day dosing drug, so compliance is better with nadolol. It's a very strong beta blocker, has very strong beta blocker effect, so it lowers the heart rate of the patient significantly. So that's why, you know, I really like nadolol, and this should be your beta blocker of choice. Okay, so if you notice, all my long QT patients, all my inherited arrhythmia patients, not SVT, but the inherited arrhythmia patients are often either on propranolol or nadolol. Okay, of course, propranolol more in babies, but nadolol after infancy. Okay, so if you see a patient on nadolol, he must have some inherited arrhythmia. Okay, more must, but usually has an inherited arrhythmia. Okay, so there is an extended release propranolol that we don't have, so to avoid this TDS dosing or 3 times a day dosing. Okay, so so nadolol is your drug of choice, so that's why the kids of this patient are already on nadolol. It's usually 1 per kilo starting, you know, 0.5 to 1 per kilo starting dose. 0.5 is the starting dose. Then you go up to 1 per kilo, and then you can go up to 2 per kilo, and you can go up as much as tolerated. With beta blockers, you can go up as much as tolerated. Often, you know, it's difficult to go above 3 per kilo. Okay, it's a high dose. Okay. Another therapy is flecainide. Flecainide, like remember we said calcium gets abnormally released from the sarcoplasmic reticulum, and that calcium is exchanged with sodium, remember? And so flecainide is a sodium channel blocker. It blocks that, it helps blocking that exchange, okay? So yes, calcium gets released, but it is more difficult for that calcium to be exchanged with sodium and then causing after depolarization. Make sense? Yes, guys?
Yes.
If it's confusing, you have to interrupt me and tell me repeat. Confusing or not confusing?
تمام يا دكتور.
تمام? Okay.
Clear.
Okay. So, and also flecainide also affects the ryanodine receptor. So it has, you know, flecainide works by blocking sodium channel, but also blocks ryanodine receptor from releasing calcium. So flecainide has dual, you know, benefits in such patients. So flecainide is a really good drug for CPVT, and that's why our patient had a significant improvement of arrhythmias when he was on flecainide. However, he was not compliant. Okay, so flecainide is also a very good drug of choice. However, when you have a patient with CPVT, we don't do flecainide solo therapy unless you have a contraindication to beta blockers. Like our patient who had severe asthma, we never tried beta blockers on him, but apparently his asthma is very bad. And I clarified this with him, and he tells me that his asthma is very bad. So I understand why people were afraid from beta blockers. So, but however, you know, people are generally not very comfortable with flecainide solo therapy. So you can do beta blocker plus flecainide. However, flecainide only is usually it's atypical. Okay. So let's say a patient is already on beta blocker and already on flecainide and still having symptoms, then you could think of left cardiac sympathetic denervation, which is a very 10 to 15 minutes, you know, it's a quick surgery to, you know, de-innervate the heart, okay? Unfortunately, it's not super effective as expected. You would think that if you de-innervate the heart, you know, the disease would really improve, right? Because again, there's no adrenaline input. So then, you know, your symptom would be less. But studies have shown that even with patients with left cardiac sympathetic denervation, 30% of them still have persistent symptoms. So it's not super good, but it's an option, of course. And if you're desperate, you already did beta blockers, you're already on flecainide, you might as well do left cardiac sympathetic denervation if the patient continues to have symptoms. And then you, of course, use ICD as a last resort. Usually people do beta blocker flecainide, beta blockers only. Then add flecainide and then do left cardiac sympathetic denervation plus the ICD at the same time, or do left cardiac sympathetic denervation first and then ICD. But often, because of these frequent recurrence of symptoms with left cardiac sympathetic denervation, usually you do ICD plus left cardiac sympathetic denervation at the same time. Okay, so this is your, these are your options: beta blocker, flecainide, left cardiac denervation, and ICD. Okay, ICD is not is last resort. Do you guys know why? And specifically for CPVT, anyone knows why? Besides, this ICD complications, potential complications. If you have an ICD, that ICD is not perfect. بمعنى, it might provide inappropriate shocks. Let's say the lead got fractured, and then the ICD malfunctioned and delivered a shock while you are fine. Of course, that shock is painful, right? Your adrenaline would go up because of that inappropriate shock, and this would induce ventricular fibrillation. And then this would be, the patient would be in storm because the device would keep giving inappropriate shocks, and the patient would be, artificially induced VF, and the patient might die because of that. So the ICD, you don't do it, you don't, give them ICD lightly unless there is no response to therapy. Okay, so ICD is only last resort. Makes sense? ICD, if someone has an ICD, just keep, imagine God forbid you have an ICD and you're worried that ICD would shock you anytime, right? So this is a stressor by itself. Okay, so and very often, especially in pediatrics, you get inappropriate shocks from ICD because of high rate of lead fracture, lead dislodgement, plus when the patient, there's higher chance of patient having sinus tachycardia because they are young and healthy, and the device might misinterpret that sinus tachycardia as ventricular tachycardia. Okay, makes sense? Okay, so according to guidelines, so let's go back to the HRS or North America guidelines. So when you have a patient CPVT, of course you have to limit sports, right? Makes sense. Like our patient, he stopped swimming. Okay, so that's the number one something to do. So limit competitive sports, limit strenuous exercise, limit exposure to stressful environments. If let's say he's working at a stressful, job, so he has to quit his job. Okay, and then of course beta blockers are recommended in all symptomatic patients with CPVT. This is class 1, and ICD is recommended in patients with diagnosed CPVT who experience cardiac arrest or symptoms despite medical management and left cardiac sympathetic denervation. Okay, so ICD if you have symptoms despite drugs plus left cardiac sympathetic denervation. Okay, like we said. Okay, class 2A, flecainide could be useful, like we said, is useful. And of course, so class 3, meaning you should not do it. ICD as a standalone therapy is not indicated in asymptomatic patient with diagnosed CPVT. So meaning if you have a CPVT patient who's asymptomatic and you just throw an ICD, that's not recommended. Okay, it's class 3, meaning it's not recommended. In fact, it's harmful to the patient. Okay, so, and then the European guidelines, it's very similar. So you have to avoid competitive sports. Beta blockers are recommended, of course, in all patients with clinical diagnosis CPVT. So all patients, whether they're symptomatic or asymptomatic. Okay. ICD implantation, in addition to beta blockers, with or without flecainide, is recommended in patients with a diagnosed CPVT who experience cardiac arrest despite optimal therapy. Again, if you have symptoms despite optimal therapy, ICD only then ICD is recommended. Okay. Okay, so because of the flecainide, flecainide is class 2A, like the North America guidelines, because there's less evidence of flecainide. It's only recently have been utilized, so probably it might go to class 1 eventually, but so far it's class 2A. Okay. Okay. So, this is an example of a patient who had, frequent PVCs. So this bar represents how often this patient has a PVC or VT. And then once the beta blockers starts, then the PVC or ectopy decreases so much. Okay. So, a couple of studies have confirmed the response to beta blockers. So, if you are on beta blocker therapy, you are less likely to have, you're more likely to survive. Okay. And if you are not on beta blocker therapy, you're more likely to have cardiac events. Okay. So this is another study that included 110 patients and all on beta blockers, and the risk of recurrences was 26% for those patients. So beta blockers are effective at 75% of patients, okay, in general, okay, which in this study also confirmed that recurrence rate, okay. So this is another study that confirmed the superiority of nadolol compared to beta-1 selective beta blockers such as atenolol. So if you have this red bar or red piece of the bar is how much non-sustained VT these patients would have. So if they are not on treatment, there's so much non-sustained VT. If you are on atenolol, there is less non-sustained VT. However, if you are on nadolol, there is even way less non-sustained VT. Okay, makes sense, guys?
Yes.
Okay, so nadolol is superior to other beta blockers. Okay. So of course, when you start beta blockers plus minus flecainide, you have to do repeated halters. Again, because if there is ectopy here and there, it's often asymptomatic. So you have to make sure there is the patient, yes, he's asymptomatic, but you have to make sure there's not much ectopy that is subclinical. Okay. And remember that, when someone is, let's say when you're running, when you're late to work and you're running to work, for example, yes, your heart rate might not be very fast because you're running a little bit, but because of the stress of being late plus the little running, this might cause symptoms. Okay, so this is only seen on a halter. Like if you do stress test for a patient, I mean, the emotional stress is not there. It's usually just the physical stress, but the emotional stress is not there. However, in real life, there is, physical stress with emotional stress at the same time, right? So halter is good to screen for such, stressors, okay? So halter is a must. You can implant loop recorders, again, to monitor ectopy. You can tell them, if you know the patient threshold, you can tell them to, wear a, heart rate monitor, like watch. And if he is around his threshold, he should calm down. Let's say his threshold is 120 and he's playing around with his kids. And if he's above 120, he should stop playing. If he's, as long as he's below 120, he can continue playing, right? So that's a nice way to monitor himself, okay? And then, of course, you do exercise stress test and exercise restriction. Make sure he's restricting himself from exercise, okay? Okay, so in conclusion, that's a rare arrhythmia that is catecholamine induced. Stress test is often the only way to clarify or to confirm the diagnosis. Okay, it is high penetrance. Again, like in this family, there are so many patients who died. So if you have a family of CPVT, you will find so many patients who are symptomatic. Versus if you have a family with long QT, it's not the case. Usually it's less frequent, the symptomatic individuals. Most individuals are silent, okay? However, in CPVT, many individuals are non-silent. They are, they show themselves, they die, or they have ICDs, or therapy, cardiac arrest, and so forth, okay? So it's a rare disease, but it does exist. and usually exists in the, occurs in the pediatric age. So that's why it's important for us. And we have to always think of it when you see a patient who had weird syncope on exercise. That's why when you guys call me, we have this syncope patient, I tell you, was it, I need history, because if you tell me he's exercising and he had syncope, that's a red flag, okay? Usually syncope is the syncope is that, he's actively exercising and suddenly collapses, not, versus the vasovagal type is that they are running, they get tired, they relax, and then they faint. This is not CPVT. CPVT is they are actively running, suddenly they are collapsing, okay? Not running, and then the kid got tired, and I sat down, and then, tired, sweaty, and then fell down a little bit, and then woke up. This is more vasovagal, not a red flag, okay? So you have to clarify the syncope history when you take history. Oftentimes, I just get a call, there is a syncope kid, but, I need further details. You should ask these details, okay? So genetic testing is recommended, and it's usually 80% sensitive, okay? And the beta blockers or Nadolol is the mainstay of therapy, okay? Okay, questions?
Thank you so much, Mohammed. صراحة beautiful lecture and review for CPVT. Thank you. One question. What's the name of the family, just for a case of curiosity, because is the parent are related?
No.
What's the name?
Non-consanguineous. The patient mom and dad are non-related, and his new wife is also not a relative. I cannot tell the family name. I can tell you, later. But I cannot
later. Just want to know, because we have many cases like this. As you know, we have the big family of non-QT and the other ones.
Yeah, it's a rare disease.
Just to be aware.
Yeah, it's a rare disease. This is my first CPVT family in Kuwait. Of course, there are more, but this is my first one. So long QT is way more common, But
yeah.
Okay.
Thank you.
Welcome. Any other questions?
Mohammed,
Yeah.
Do you hear me?
Yeah.
Mohammed, excuse me. What about the adult part? If you contact with Dr. Ali Fouzi, how many patients they have and how they treat? I mean, how experience for them? It's interesting.
Well, they referred this family to me for the kids. Okay?
Yes, I got it.
But they did not. He was diagnosed with idiopathic VF, so there was no diagnosis because CPVT is it's not very well. I mean, people don't think of it as much. And people don't do genetics, especially the adult people don't do so much genetics because they have been disappointed in the past. So there are reasons for it. But usually they nowadays they are whenever they have someone with arrhythmia that is inherited or significant, and this someone has kids, they refer them to me usually in general. I mean, not all the time, but most of the time. So that's then when I inherit these kids, I usually investigate the parent, because the parent has the disease for sure. The kid may or may not have the disease. So I grasp the parent, I take good history. So this parent now is my patient. So I do the stress test for him. I do his ICD interrogation. Now he's mine, So I investigate the parent, then we try to diagnose something, then we worry about his kids, to be honest,
because I think it's not too much investigated till now. Maybe in America is better, because America they're doing a lot of genetics tests, right?
Yeah. So I try to, because I go to the EP lab all the time, and whenever there are ICDs in young people, I always review the family, the patient, and this is how I get patients, But you're right. Of course, we're missing so many, of course,
But that's my feeling is that we are missing a lot. Now
in the army, for example, just 2-3 years ago in the army, there are like 2-3 individuals who passed suddenly while being trained for the army, And these patients are definitely long QT syndrome, CPVT, something, arrhythmia, you know?
You know what? Yeah, because I'm not familiar with it at all. But now I'm listening and remember, a few cases straightforward what you told. When they did the running, in our place, people do a lot of exercise running, by on timing, and they sudden death.
Like when you see someone like basketball player or soccer player suddenly collapsing, that's either hypertrophic cardiomyopathy who had or long QT or CPVT.
For sportsmen,
Yeah.
But for sportsmen, we are going for hypertrophic cardiomyopathy. That's true. But as young generation, it's exactly teenager ages, and it was big, because if the patient, young boy or girl died and the exercise, in the school is a big deal always, any place in the world.
Yeah. So
and then what?
So this
I think it's not.
If you were here, this family history,
from the start, I was not here. I was busy. I'm on duty.
Yeah. So one of his nieces died in school after being yelled at from the teacher. The teacher yelled at her and she died because she was nervous. And this caught the media attention. And this teacher went into big trouble because, people were blaming her that she was too aggressive and the kid died because she was too aggressive. But, this kid had something that made her prone to death. So, it's unfortunate, of course. But, it happens,
Yeah, that's why, Mohammed, two more issue. Yeah, we should be less aggressive, try to avoid any stress and to make our life more comfortable, and everybody should do who is surrounded by us and we surround by people, because stressful for sure for everybody now, so actual. This is one more point. And our doctors who has a history of some arrhythmia as well. This issue, this is
so again, if you have someone who had a very suspicious syncope and had a normal ECG, stress test should be your workup. But you have to, your first job you have to obtain a very good history, and then and then figure out this patient deserves a further investigation or it's a benign vasovagal syncope. That's the most difficult something to do. You have to filter the patient and then selectively investigate patients who are very suspicious of true arrhythmia versus your typical silly vasovagal faint that we usually don't do much. We usually just...
But you will order exercise test, or you will order the Holter first?
No, I mean, if it's vasovagal, I don't do anything much. Of course, but
no, because there's a lot of Holter. You know what I mean? Each case was, even today, there's somebody called me, he has some fainting attack, and they straightforward want Holter. You know because we are doing overload the Holter, right?
And then we're having complaints that from the Holter department that we are over abusing our...
Yeah, I know, but this is bad money.
Honestly, it's our fault because we don't take good history. If the syncope is very benign, meaning someone was standing hot, humid, or taking a shower, it's very hot, very humid, and then he tells you, I became nauseous and my vision went tunneling black, and then I fell. I quickly woke up. You tell his mom that's normal. Just go home. Don't come back. In a nice way.
For that part. Need
but you don't have to Holter for this patient. You don't have to do even ECG. You don't have to do echo. You don't have to do MRI. You don't have to do anything for this patient who had a typical vasovagal syncope.
Yes, that's why what they're calling and ask is not enough. The parents should come and somebody should talk precisely about the history, because history number one, really. Because on call is you can't take the history fully. It's impossible.
Yeah, a true syncope. If someone definitely fainted, you have to get history yourself. But if someone tells you it became dizzy or whatever, this is usually less worrisome. But if someone truly fainted, at least just take good history and then decide, does he deserve EP evaluation or he doesn't deserve? 90% of the time, they don't deserve EP evaluation. Only 10% of the time that they deserve someone else to take more history and maybe do more investigation. Okay.
Yeah, this is really interesting. Thank you so much.
Welcome. So yeah, so since
but we should repeat, a little bit, because it was too much information from the start, but it's okay because I'm missing the first part.
Yeah.
This is first ECG when you explain QT, this one, Brugada, but it was not Brugada, it was normal ECG.
Yeah, it's just incomplete right bundle, right. But because of lead positioning, not even because it's true. Yeah. So
Mohammed, you can talk about the Brugada next time, because I really do remember little cases. If you have.
I'm still waiting for a typical Brugada patient, to be honest.
You don't. Yes, that's why I'm asking.
We have a Brugada patient, but they usually
family. Do you know we have one family they did in London this ASD.
I have two families with Brugada.
I know one.
They are adults. Most of them are adults, and they are not very usually asymptomatic, atypical. So no, I don't have a very interesting typical story of Brugada. This is a typical CPVT story. So one day when I have a typical Brugada story, we'll discuss it. I have long QT patients that are very interesting. One day we can discuss. But I have a couple of ARVC, but they are adults as well. So ARVC Brugada more adults, more CPVT long QT more pediatrics. But of course, we'll do this. It's inherited arrhythmias in general are very interesting. And people should not miss them because they might die. So they are not like SVT. They're still do drugs. They are different beasts. Yeah.
Mohammed, you think this? You mean right ventricle? This oh my God! This for adult you told is most common.
ARVC.
This
ARVC.
Yeah. Oh, yeah. I forgot how to tell. Are you sure this is mainly for adult, not for teenager ages?
No, it happens in teenager, but it's more. It usually manifests. It's a little bit older in age. More teenagers, young adults.
Yeah. What I know, even 40, 15 years like that. What I even saw.
Not like 6, 7, 5 years. Of course, in babies. But CPVT usually 8, 10 years onwards. Like we said, at least 30% would already have symptoms by 10 years of age, CPVT. But ARVC is a little bit older, and Brugada is definitely older even,
But excuse me, Mohammed, do you have some arrhythmogenic right ventricle? You have some story, some patient?
Well, I think I have at least one family.
With arrhythmogenic confirmed by MRI, you mean, right?
Yeah, MRI confirmed.
Yeah, because only by MRI you can confirm. Echo nothing to show. And even they come in with extrasystole or VT, what I know from the start.
We can discuss them. I think we have at least one family ARVC. I have one family of Brugada for sure.
This is good. It will be good. It means practically going.
But I discussed this family because again, it's very textbook family, so it's very interesting.
Yes, really.
Yeah.
Really. Thank you so much. And you see there, how long they should take Nadolol? Forever?
All life, throughout life.
And you will increase only dose, what I understood, right? By ages.
Yeah, they are still 3 and 5 years old. We start at 0.5 per kilo. I just started them last week. They are fresh family, So last week I started Nadolol, and then I told them to come back this week for this next clinic for ECG, heart rate monitoring. If they're not very bradycardic, we'll probably go up to 1 per kilo per day, and then we'll keep them at 1 per kilo per day. They don't yet have any symptoms to begin with. But they will manifest one day if we did not start drugs. So we are ahead of the game, and hopefully they will never have any symptoms since they are on drug. Because if they are compliant with beta blockers, roughly 70-80% of them will be fine, will be good, will remain asymptomatic. Only 20-30% of them will be difficult to treat.
And you see, I miss one more thing. In such case, you will add flecainide. In such a, when you will decide to add flecainide?
Well, if they are on beta blockers, compliant, but they still have VT. then you add flexion.
Yeah, I got it. You mean if it's still with the VT only in such case, and another case is okay, no need to
Yeah,
add
no
it,
need.
but
Yeah, most of the time, no need. But flecainide is a good plan B adjunct to beta blocker. It's a very good one. You don't, by the way, you don't use calcium channel blockers. I mean, it might make sense to people, but calcium channel blockers are not therapy for CPVT.
Yeah. That's what I understood, Mika. It's very good that you show this depolarization, repolarization. Always we are missing. And about the adults, they are doing this this treatment, the said one, the sympathetic denervation. They are doing because it's quite familiar. They are doing for people.
Our thoracic surgeons does it, but not very frequently. So the experience is not the greatest, but they do it. They do it. Once or twice a year. They do it. Yeah. So
who is patient for whom they do it?
Well, they do it. Our thoracic surgeons, they do it, but they told me once they want at least 35 kilos and above. So they cannot do it in pediatrics unless they are 35 kilos and above. So, you know.
With confirmed CPVT, you mean? They're doing for adults?
No, they do it. Usually they do it for adults. So adults sometimes they have VT, ischemic VT.
Right.
And they did ablation, they did ICD, they did and they are not still having VT. They do it.
Yeah.
Okay.
They do it because it's not only for CPVT. Yeah. What I know. Ischemic. What I mean, right?
The adult they do it for ischemic VT. We do it for long QT and CPVT. We do it for long QT as well and CPVT. But long QT.
Thank you so much.
It's a very good surgery for long QT.
Yeah. And it's interesting. Yeah, that's what I had. But I know we are not doing it here. But for adults, if they do 1-2 cases.
For adults, they do it. Yeah.
Okay. Thank you so much. Take care.
Thank you. Anyone else has questions?
Everybody left, maybe only we are talking.
Ali today is quiet. يلا اوكي.
لا يا باشا والله مش قوة ولا حاجة، بس موضوع جديد يعني وحلو. تسلم يا كبير والله.
اوكي يلا مشكورين.
شكرا يا باشا. اتفضل يا باشا اتفضل.
شكرا جزيلا.
السلام.
شكرا دكتور محمد.
مع السلامة.